topic I'm going to present is from pediatric orthopedics. So this is a sort of a picture that you can be presented with to start the Viva discussion as well. And now, looking at this picture, there are few things that you can pick it up, that the leg is short and that is externally rotated. So immediately there are few things that can come into your mind. And if you are fully prepared, just by looking at this picture, you can take the whole Viva. And that is the main trick in the examination, that you should anticipate the questions that will be coming next. Okay. Similarly, you can be presented with an X-ray as an opening question and comment on these X-rays. So the topic I'm going to discuss today is about slipped upper femoral epiphysis. And that topic was asked from me as well. The important point in this is that sometimes they can present you with an X-ray which is just an AP view and you won't be able to see much. And in these examinations, it is very unlikely that you will be presented with an X-ray which has got normal findings. So just keep this in mind. So always ask for a other view, which is the lateral view or any other further imaging. So these things happened to me in 2 occasions, one on in this and also another X-ray which was a shoulder X-ray, and the X-ray was pretty normal on the AP view. Okay, so keep this in mind. Is a fellowship exam, it is very unlikely that you will be presented with a normal X-ray. Okay, so coming to SUFE definition, everyone should be aware of that. Is a disorder of the proximal femoral metaphysis that leads to the slippage of the metaphysis anteriorly and superiorly. And it is relative to the epiphysis, which remains anatomically positioned. So basically, the head stays in the position. It is the proximal femur which displaces, and therefore we get this presentation or this condition. I've highlighted these important bits or important buzzwords that you need to say in the red, that will inform the or tell the examiner that you're aware of what you're talking about. Okay. There are a few facts to remember. Again, it is more for the written part, but still in the discussion you can come up, if you get asked, you can be throw this information to the examiners. So it is more common in boys, more common in African and Polynesian descent. It is more common on the left side, and it is associated with an increased weight, with femoral anteversion, and there are hormonal conditions which are associated, such as hypothyroidism, and just few more. Okay. So a typical presentation of SUFE is an overweight child with purely localized groin, thigh, or knee pain, and he is limping. There may be a history of minor trauma, and the usual age of presentation is between 11 to 14 years. Okay. And on the clinical examination, the leg is shortened and externally rotated. There is restriction of movement, especially flexion, abduction, and internal rotation. And there may be additional external rotation when you try to flex the hip. Investigations are pretty straightforward. Plain X-ray, AP, and the true lateral views. People don't recommending doing a frog lateral view because it can further displace. Okay, so therefore, plain AP and the lateral views are enough to get the diagnosis. There are few radiological features that you are looking for, such as positive Beethoven sign, which is also called Kleins 9. Decreased epiphyseal height. This is a subtle sign, so you have to be careful, or you have to be mindful when you are looking at these X-rays. There may be increased distance between the teardrop and the femoral neck metaphysis. And there can be widening and irregularity of the physeal line. And then in delayed presentation, there can be remodeling and sclerosis. Okay, so this is how the clean eyes is seen. So on the left side is the normal one, in which you can see that when the line is drawn through the upper end of the neck, the part of the line passes through the femoral head. But if there is slip, then that line will not pass through the femoral head, as you can see on the right side. Okay. Further investigations include CT scanning to find out the degree of the slip and also the version of the hip. Ultrasound scan can be useful for early slips and also to look at the joint effusion. An MRI scan to look at the avascular necrosis. But these are all supplementary investigations. In terms of diagnosis and the history, clinical presentation, and plain X-rays, most of the time should be able to give you the diagnosis. Okay. The classification can be divided into functional classification, which is divided into two types, the stable and the unstable. The stable is able to ambulate and bear weight. An unstable slip is a patient is in severe pain and unable to ambulate with or without crutches. I think in this topic, everyone should know about the loader paper. And if you are asked about this, throw this information as soon as you can, that you're aware of this paper, and mention it to the examiner. It tells you about the stable slip and the unstable slip. It was a multi-central trial, and they look at the 54 children who had 55 slips. And what they found that the avian developed in 47% of the patients with the unstable hip. Then there can be other classifications like chronological classification, which includes pre-slip, then can be acute, chronic, and acute on chronic. The difference between acute and chronic is the time and the duration of the symptoms. If there's abrupt displacement in the short period of less than 3 weeks, it is acute slip. And the chronic slip is the groin pain, medial thigh pain, knee pain, and presents with more than 3 weeks of duration. And acute and chronic, as the name suggests, the symptoms are of more than 3 weeks duration, but then they present with sudden onset. Okay. On the X-rays, you can also do the grading of these slips. Most commonly done is the Southwick angle. Now, there are a few things again which you should know about the Southwick angle. One, it is the difference between the two sides. So you look at the normal side and then look at the angle on the other side and then subtract it, and then that's how you calculate the slip. And it is measured on the lateral view on both hips. So the Southwick angle divided into three types: grade 1, grade 2, and grade 3. Grade 1, angle difference of less than 30 degrees. Grade 2, difference of more than between 30 and 50 degrees. And grade 3, severe, which is difference of over 50 degrees. Okay. So more severe the slip is, more likely is to be unstable. Okay. This is the radiological presentation of measuring the Southwick angle. I don't think they will ask you to draw the angle, but they would expect you to know the values of these angles. Okay. Now we come to the treatment of this condition. Now, what are the aims? The aims is to prevent any further progression of the slip and without any complications. For the stable slip is very simple and straightforward. I think there's hardly any controversy, and that is pinning in situ. However, for the unstable slip, there are different school of thoughts and different people say different treatment options. But again, the aim is still the same, to prevent any further progression of the slip and to avoid any further complications in future. Unstable hip, as we discussed earlier, they've got high risk of AVN. Okay. And pinning in situ can be technically difficult because of the degree of the slip. And some people have more aggressive approach, which is open reduction of the hip. And then there are different types of osteotomies that can be performed to reduce the hip, and once reduce the hip, to stabilize the hip. Okay. The most commonly done is the Dunn's osteotomy, which is the trochanteric osteotomy, which is through the growth plate. Okay. Rest of the them, I have not seen them personally myself, but again, if you work at different centers, the most commonly done is the Dunn osteotomy. Okay. Now, pinning in situ is something which they can ask about the surgical technique of that as well. Now, the points to remember in that is the entry point is more anterior than you normally think of. Okay. And there are different ways to identify the entry point. One way is that you look at the position where you want to put the with screw on the AP and the lateral view, and then draw the lines. And where the lines are intersect, that is your entry point. Okay. So I think this is if people have not come across with that, I would suggest to go through it and have a clear plan. How you, if somebody asks you how are you going to pin, have a operate plan in your mind, positioning of the patient, what are the aims, how are you going to achieve, what type of screw are you going to put in, and how many threads you will pass. Okay. Now, this is just a flow chart. I've taken this from postgraduate pediatric orthopedics, and I found this book quite useful for pediatric orthopedics. This is again quite a useful chart. And if you just remember this chart, I think you can answer most of the questions. Again, as we discussed earlier, it has divided this in the two main categories: stable slip and the unstable slip. And then depending upon how severe it is, there are different treatment options. Okay. Similarly, this graph also simplifies the treatment options. This one, I've taken it from a paper from Uglu and Clark. That's the other paper I think people you should know about it. And again, if you're given an opportunity, mention it in the Viva. This is a review article, and the consultants work around Southampton. And again, they have simplified the treatment options and explain it in quite detail, that what you are expected to do if you are come across with a stable slip, and what are the options if you come across with an unstable slip. Okay. Now, a question can be asked if you're doing very well regarding the timing of the surgery. And this is something which is, again, controversial. For pinning in situ, again, that's not a big issue. You can do it as soon as possible. But again, it is not something which needs to be done in the middle of the night. You can plan it and then do it. And probably in these days, probably consult the pediatric orthopedic surgeons before doing the pinning. Okay. There are a few papers which I have mentioned, which have given different opinions regarding the timing of the surgery. Lorenz et al. Meta-analysis of 5 studies. They looked at the 130 unstable SUFE, and then they concluded that AVN risk decreased if the treatment occurred within 24 hours. Again, keep in mind, this is again for unstable SUFE. But they also mentioned the difference was large, but it was not significant. Other paper, Peterson et al., they look at 91 acute slips, and they also mentioned that early stabilization was associated with less risk of AVN. Loader et al. Looked at their study. They showed that 87% of the people or patients developed AVN when treated within 48 hours. But again, most of their patients were having an unstable slip. Okay. Now, the other question can be asked, what are you going to do with the other side, which does not have any symptoms? Okay. If they are symptomatic, then the answer is straightforward. You will fix it. But if the other side is not symptomatic, then again, it's a controversial topic. But there are certain factors that can be considered if you are planning to fix it on the other side. Age of the patient. If the child is less than 10 years of age, it is associated with higher risk of being bilateral SUFE. If the etiology of endocrine disorder, again, they have got high incidence. And if you feel there's a poor compliance of the child and the parents, then you can consider fixing it other side. Okay. And then also nature of the current slip. If the slip is severe, then it may justify pinning the other side. Okay. That again, I think it is important. That's why I put this slide again, to know the surgical technique of doing a pinning in situ. Normally done under general anesthetic with IV antibiotics. Patient supine on the fracture table. Important thing is to mark the trajectory of the screw and use the fluoroscopy as for your advantage. Okay. The entry point is quite interior, what you normally expect from doing a DHS. A 7.3 millimeter or 6.5 millimeter fully threaded reverse cutting screws are used. Important thing is to avoid the blind spot. And the way to avoid the blind spot, again, to use the fluoroscopy and use different, not only AP and lateral, you can have oblique views as well to make sure that the screw is not going into the joint. You can also use an arthrogram through the screw to see if it is going into the joint. And post-operatively, you start with partial weight bearing leading to full weight bearing. Okay. The complications, we already discussed. We're doing all these things to avoid AVN. Okay. It can cause chondrolysis, which is a rapid and progressive loss of articular cartilage in patient present with severe pain. There can be residual deformity, and it can develop osteoarthritis, and there can be leg length discrepancy. Okay. So I think this is a very simple topic. If it's come to your viva, is the loader paper and the Uglu and Clark paper. And I think if you mention all these things, I'm pretty sure you will do well. And
so say there's controversy about.
I agree with Sean, and I think I did mention that if you are asked about this question, you do mention that you will discuss with the pediatric orthopedic. But if they ask you about the surgical technique, again, you can say that you should know the principles, and that's how you will answer that. The principles are that I'm going to do these are the principles, and that's how I'm going to treat. But I will discuss it with my pediatric orthopedic colleagues.
Okay, so I'm going to just reinstate exactly what they have says. It's a very important topic. You guys need to know that these are the topics. It should be considered gift in the exam, and when they come, you should score high so that you can participate at other places. The other thing, what Sean always says, and I second him like no one. Whenever you say this is a specialist problem or this is a pediatric specialist problem, you say the same sentence in one breath. Please don't stop.
Yes.
This is a pediatric specialist problem. However, the principle of management are, please don't stop or else they will intervene. And the less the examiner talk, the better it is for you. So we'll talk to Himanta and then we'll.
Yeah, it's all great, Fouad. I think with these presentations, guys who have read this again and again might find that it's a bit repetitive, and it's just repeating whatever the textbooks are saying. But that is the importance of the exam, that you need to know the basics really well. It's going through all the mundane basics that will get you to score a 6. It's being able to vocalize what exactly you're going to do with this patient in A&E. That's how you pass the exam. That whether this patient is being able to weight bear or not. So those are the key things. You have to verbalize those one after the other and bring them out. And they might take you in depth of one particular thing that you have mentioned, but that's all right. As long as you stay on track as how you're going to manage this patient in A&E and thereon. And there would be, I've seen this a couple of times in courses that pediatric surgeons, because remember there will be a pediatric specialist in the Viva table, they're very keen to start this question on a child who is presented with an injury to the knee or knee pain.
Mm.
They often do this. So beware of the child presenting with knee pain. Always think of the hip. Okay, that's all I have to add. Thank you.
I think this is a very important point. Always, this question always starts with knee pain. I got this question and it started as knee pain. And I'm sure whoever has got this question in the exam, it would have started as knee pain. And it's a minor trauma to knee with which the patient come in. So that's a very important point to ponder. Fawad, there are a few questions. So the first one I have answered on your behalf, but I will ask you to second it. They were asking how many threads supposed to pass through the physeal. So I say 3 to 5 depending, and 5 millimeter below the subchondral.
Yes.
And then the other question is,
just
what
on
is
the question of threads? Sorry, there is another point on the threads. The reason why they talk about no more than 3 to 5 is because if you try to cross all your threads across your growth plate, you will definitely have a high incidence of breaching into the joint surface. The other point is the reason why Fouad was pointing out that it's much more anterior than you think. In an in situ fixation, your epiphysis is now posterior to the neck. So you're not aiming to get up the neck straight. You're aiming to put the center of your screw in the center of the epiphysis. So therefore, you end up being anterior in the neck automatically. So just be aware, those are two things that you need to get down correct. You're aiming for center of the epiphysis, not center of the neck. And you're also aiming for the no more than 3 to 5, depending on the age of the patient, but not to cross the entire physis with your screw.
Okay. The other question what they have asked is about the blind spot, Fawad. What is the blind spot?
The blind spot is if you are not careful and if you're looking at only in the AP view, it is possible that again because of the slip, the screw may go into the joint and breach the articular cartilage, and that you don't want to do it, because if you breach the articular cartilage, then the chances of chondrolysis becomes more, and therefore it is suggested that you do the X-rays in different views, not only in AP and the lateral, and certain oblique views as well, to make sure that the threads are not going into the joint.
Okay, thank you very much. There is someone else asked one final question, and then I have one question for you. Is how do you diagnose chondrolysis?
I think it again is a clinical presentation. what I have seen few patients with chondrolysis is they present with severe pain in the hip with the history of SUFE in the past. Okay, but in terms of investigations, again probably X-rays and then MRI scan would be helpful.
Possibly
But
MRI scan,
yeah.
yes. MRI with gadolinium or something, an enhanced contrast MRI scan that shows the physeal cartilage. But we are all, Fouad, are you aware of this new controversy of an acute slip to reduce it? Because Southampton guys are reducing it, and this is something which is new that has come into the exam.
Yeah, again, as I said, there are so much controversy about the treatment of the unstable hip, but I'm not sure what the guys in Southampton are doing. I have worked in children's hospital and in touch with them guys, with the patient who present to our hospital. Their policy is generally to wait. So I think I didn't mention in my presentation, if you decide that patient is, if it's an unstable slip and you are not going to do it acutely, then you put them in a traction for about a week. That will allow the things to settle, and then they plan the surgery accordingly, and then they don't do fixation in situ, rather than they consider doing an open reduction internal fixation like a modified done osteotomy.
By Sean, and very good point by Himanta. So all of the mentors have very positively contributed to this very positive cause. Positive thinking can heal the world. So I'll hand it over to Firas. So someone is saying, when should we remove the screw? We should not, if possible. It's only add 10 more minutes to a future hip replacement if need be.
Yeah.
Okay. Should we move on?
Yeah. Hi,
Okay.
Shwan. Hi, Shwan. So thank you, Fouad, for presenting. Sorry I missed it, but it's very good of you to present, and I will, Athar will